Welcome back everybody, David here again with Med School Boot Camp. So in this next video, we are now going to talk about thiazide diuretics. And if you recall from our previous videos, we talked about the different areas of the nephron where we first in purple kind of had our PCT, right? Blood is filtered at the glomerulus, goes through Bowman's capsule, PCT. Then we talked about a medication, loop diuretics, that happen to work in the loop of Henle. And now we're turning our attention to thiazide diuretics, which typically act at the distal convoluted tubule. So if you haven't seen our previous video on loop diuretics, I really suggest you go back and watch that one because a lot of the principles that apply there also apply here to the thiazide diuretics. Because with this video, I really want to build on those concepts and build on that content and really talk about what are the differences with our thiazide diuretics relative to our loop diuretics, because there are so many similarities, one of which is where they actually act. So thinking about the mechanism of action here, we're going to talk about a couple medications. We have our hydrochlorothiazide, our chlorothiazide, and then we have what are called thiazide-like diuretics, including chlorothalidone and metolazone. And the mechanism here involves inhibition of the NCC channel, which is the sodium chloride cotransporter. Remember in the previous video on loop diuretics, we talked about inhibiting the NKCC channel, which stands for sodium potassium chloride cotransporter. I remember the CC at the end for the two chlorides that are actually inhibited. And this is the NCC channel, which is the sodium chloride cotransporter. And so if you draw our attention over to our diagram, we can see the channel that's actually inhibited is right here. And when this happens, a lot of things are going to occur. One of which we're going to increase the excretion of sodium and chloride / delivery to the collecting duct. We talked about this in the last video as well. If we block sodium reabsorption here, the collecting duct, which is the final portion of the nephron, is really going to have our last ditch effort to reabsorb that sodium. So we're sending more of those molecules, right? If we're not reabsorbing the sodium here in the DCT, more of them get sent down through the collecting duct, and thus we're going to have more effort here to reabsorb those molecules, or they will be excreted from the body. And so that's the first thing, and I think that makes sense intuitively. If you block a channel that typically brings back sodium and chloride, then more of it is going to remain in the tubular lumen and thus likely be excreted from the body. Now, as we know, because we're talking about the kidneys, it can't be this simple. So what else is going on? What are some downstream effects that are going to occur? The first of which is that we have increased potassium and hydrogen ion excretion later on in the kidney. Again, same thing we talked about in the loop diuretics video. If we send more sodium distally to our collecting duct is going to make every effort to bring back that sodium. However, because of the transporters that are in the collecting duct, this is going to come at the expense of potassium ions and hydrogen protons. And so in order to bring back the sodium, we put more hydrogen and potassium into the collecting duct. Ultimately, this is excreted in the urine itself. That is why we decrease the amount in our body. Now, another downstream effect of inhibiting the NCC channel is going to be increased calcium reabsorption. And this acts through increased activity of the calcium-sodium exchanger. So if you turn your attention to the other side of the cell, we see we have transporter that actually faces the blood in the serum. And this is the sodium-calcium exchanger. And so why does the activity for this increase when a patient is given a thiazide diuretic? Well, the reason is if we decrease the amount of sodium in the cell, we're going to change the concentration gradient, right? Remember, we have two different things when we talk about the flow of molecules. We have osmosis, where we talk about water going from low solute concentration to high solute concentration, but we also have the principle of diffusion. And one of the principles of diffusion tells us that molecules will go from a high concentration to a lower concentration. And so if we have a low concentration of sodium inside the cell, that is going to stimulate the channel, which is going to act to bring back more sodium into the cell, because now we have a concentration of a lot of sodium out here in the serum and a low concentration of sodium inside the cell. And so sodium is going to act to go into the cell because it feels like there's more space. It wants to get away from the crowded environment and go into the cell where we now have a lower amount of sodium. Why do we have a lower amount of sodium in the cell? Because we have inhibited the NCC channel, the sodium chloride cotransporter. Now, if you look at the flip side of this, we see that bringing more sodium inside the cell results in calcium being exchanged, right? Calcium is kicked out of the cell, it goes into the serum, into the blood. And because more calcium is brought into the blood, we have increased calcium reabsorption. So again, stimulation of the calcium-sodium exchanger because of low sodium inside the cell leads to more calcium reabsorption in the body itself. And finally, we talked about where this acts already, but it's going to be at the distal convoluted tubule, typically the early distal convoluted tubule. Now, when we think about our clinical uses here, again, you're going to notice a lot of similarities with our loop diuretics. So first of which is going to be hypertension. Patients who have high blood pressure might be in a volume overloaded state. Giving them something like this, which blocks sodium reabsorption, ultimately blocks water reabsorption as well. Again, the principle of osmosis. If we block their sodium reabsorption, more water is going to actually stay in the tubule itself, be excreted from the body, and this can decrease the patient's blood pressure. We also want to use this for edematous states for similar reasons. Anytime we have a fluid overloaded state, such as decompensated congestive heart failure, pulmonary edema, or cirrhosis, we want to offload that fluid. And one thing that's really important to know, especially from a clinical perspective, is that we often will combine a loop diuretic with a thiazide diuretic to essentially offload more fluid. If a patient is on a loop diuretic, which is typically first line, and and we're not seeing the fluid offloading or the urine output we would like to see, we can then add a thiazide diuretic to give them a 2-medication combo that should really increase their urine output. Now, the interesting use of thiazide diuretics I want to talk about is its use in nephrogenic diabetes insipidus. Now, what's the problem in nephrogenic diabetes insipidus? Well, the problem in nephrogenic diabetes insipidus is that the body is not responding to ADH, right? So we have our central nervous system, right? And we are secreting ADH. ADH is normal in patients who have nephrogenic diabetes insipidus. This is different than central diabetes insipidus, in which we are having a problem with producing or secreting ADH from the body itself. Now, ADH is secreted nephrogenic, but it's not responding, right? Something's going on at the collecting duct where it's not able to actually have its effect. So we're not bringing back the free water. And so patients who have this condition are essentially peeing uncontrollably. We're unable to concentrate urine because it's just go, go, go. We are unable to bring back that water, and thus it's excreted from the body continuously. Now, how is it that thiazide diuretics can help? So while the overall mechanism of how this actually works is fairly unclear, what we think is going on is that the thiazide diuretics cause sodium to be lost from the body. So we decrease our sodium, and ultimately that's going to decrease our H2O status as well, right? We're offloading fluid or decreasing the water in the body itself. Now, what's this going to do? Well, it's going to decrease our total blood volume. And how are the kidneys going to respond to this? Well, they're not going to respond very well because less total blood volume leads to less renal blood flow. So again, decreasing our total blood volume is going to decrease our renal blood flow and ultimately our GFR. And we think that this decrease in GFR kind of slows down the process. When things are filtered, they're not moving quite as quickly. And this allows the proximal convoluted tubule more time to reabsorb sodium. That is to say, in patients who have nephrogenic diabetes insipidus, if we actually cause a paradoxical drop in their volume status, we can essentially trick the proximal convoluted tubule into working harder and bringing back more of that sodium. And thus, we know that water follows sodium and brings back more of their volume status, which ultimately decreases the amount of fluid they're losing. It decreases their urine output overall. And this is helpful for these patients because that's one of their primary problems, is they're peeing uncontrollably. And this is a way we can actually slow down that process. And finally, 2 other clinical uses I want to talk about here should make sense to you intuitively, right? I really want you to understand the mechanism. I want you to understand the pathophysiology. Because if we understand the pathophysiology, we don't necessarily have to remember all the clinical uses. They just make sense to us intuitively. If we recall that inhibition of this channel ultimately indirectly stimulates this channel, bringing back more calcium into the body at the exchange of more sodium, then these should make sense to you. So patients who have recurrent kidney stones can benefit from this medication. Why? Because it pulls calcium out of the urinary system. We decrease our urinary calcium. Again, this is due to the pathophysiology of stimulating this channel. It brings back more calcium out of the tubules, thus less calcium is in here, less calcium can actually form these stones. And so that's one clinical use. The other one that should also make intuitive sense based on our understanding of how calcium and sodium interact with thiazide diuretics is the fact that we can use it for osteoporosis. Why? We are increasing serum calcium. Same mechanism here, right? Inhibition of this channel ultimately stimulates this channel, brings back more calcium across the barrier into the serum. And patients who have osteoporosis typically need more calcium. They need more vitamin D and more calcium to build strong bones. And so this is a treatment that we can use to help get them more calcium that's already inside their body. Instead of excreting it, we'll bring it back into the serum, bring it back into the blood so we can use it for bone health. And finally, we need to talk about some of the adverse effects. So this can create a metabolic contraction alkalosis, same mechanism we talked about in the last video, right? Thiazide diuretics cause people to increase their urine output. They pee off more fluid. That's why you get a contraction of the volume status. The metabolic alkalosis has to do with the fact that we're increasing our hydrogen proton excretion. Why? Again, because we're sending more sodium distally. That's going to cause us to try to bring back sodium in a last-ditch effort, ultimately at the expense of secreting our hydrogen protons into the tubule. And this is why we get a metabolic contraction alkalosis, because we're losing our hydrogen protons and our fluid as well. Also important to note that a lot of these medications can induce a sulfa allergy in patients, and that's why it's really important to get a full medical history, their past medical history, their surgical history, and particularly their allergies. We don't want to give them a medication that is going to create another problem for them. Patients with a sulfa allergy who take thiazide diuretics are at a high risk of developing acute interstitial nephritis or a variety of other different findings. And finally, the last one I want to talk about here are the variety of different electrolyte abnormalities. So these should make sense to you as well. Hypokalemia. Why? Because we said we're sending more potassium to be excreted from the body. If we lose more potassium, it makes sense we would have hypokalemia. Hyponatremia should also make sense to us. Why? Because the whole point of this medication is that we're blocking sodium reabsorption. So if we're blocking sodium reabsorption, more of it stays in the tubule, more of it's excreted from the body. That one should be good to go. And then finally, there's this nice little memory aid that a lot of people use called HyperGlook, and that is to remember that we can get hyperglycemia with these patients. Same mechanism as the loop diuretics. We talked about that in detail in that video. I won't go over that again here, but essentially lower potassium in the body leads to lower potassium inside the cells, and the release of insulin is heavily dependent on the balance between potassium in the cells and calcium in the cells. And so ultimately lower potassium leads to less excretion of insulin in the body. This is going to lead to hypercalcemia. If we don't have our insulin being secreted from the pancreatic beta cells, we have more glucose roaming around. It's not being taken up into the cells. So more details on that in the loop diuretics video. Also, we would have hyperlipidemia, which is the L in our membrane. We can also see hyperuricemia, which is the U. We know that hyperuricemia can predispose patients to having gout. And can you remember some other things that can lead to hyperuricemia? That's right, patients who have a high purine diet, so they eat a lot of steak or they have a lot of wine. Also, patients who have tumor lysis syndrome, that's a very classic cause, right? The cell ruptures, all the internal contents leak. One of the internal contents is uric acid. And finally, to wrap up this membrane, we have hypercalcemia. Again, mechanism we've talked about previously several times, bringing back more calcium into the body can lead to a hypercalcemic state. So a classic vignette for thiazide diuretics might be something along the lines of a 65-year-old patient comes to the clinic, they have a past medical history of diabetes, high blood pressure, and they have new onset joint pain. They report that over the last 3 days, they've had a really difficult time walking because of pain in their big toe. They give you their medication list. They talk about they're taking metoprolol, they're taking a statin, and they're also taking chlorothiazide. And the question is then asking you, which of the following medications is most likely to be causing this patient's condition? Well, if you think about the options that we listed there, right, we know statins can oftentimes cause myopathies. They can cause changes in our liver function panel. This is not what the patient's complaining of. We know metoprolol can often cause patients to have a bradycardia or a low heart rate. Again, not what the patient is complaining of. They're complaining of big toe pain. This is a very classic presentation for gout. And we know that thiazide diuretics, because of their ability to cause hyperuricemia, can predispose a patient to gout. So the answer here would be to maybe stop the thiazide diuretic and switch them to another medication that can be used to offload water from their body. In addition to that, the gout can also benefit from non-steroidal anti-inflammatories, assuming their kidney function is normal. So that's just one of the ways that they can ask you this question. But again, they love to ask about adverse effects. So if you know this portion right here, you'll get a lot of the questions regarding this medication. And so quickly, just in summary, we talked about thiazide diuretics in this video. Mechanism of action, it inhibits the NCC channel here. There's a lot of similarities between this mechanism and that of loop diuretics. This is ultimately going to lead to increased sodium chloride excretion from the body, which should make sense, increased delivery to the collecting duct, and we're indirectly going to activate the calcium-sodium exchanger. We talked about that mechanism extensively. Clinical uses here, very similar to loop diuretics. We can have hypertension or edematous states, but some of the unique ones I want you to know include nephrogenic diabetes insipidus. We talked about this kind of unknown, but what we think is going on mechanism right here in terms of slowing down blood flow through the PCT, bringing back more sodium. This can also be used for patients who have recurrent calcium stones because we're pulling calcium out of the urinary system, and patients who have osteoporosis because we're pulling that calcium into the serum, into the blood, where they need it for good bone health. Adverse effects are going to include metabolic contraction alkalosis. We've talked about this mechanism extensively, sulfa allergies, and a variety of electrolyte abnormalities, including hyponatremia, hypokalemia, in addition to this hyperglycemic, right? Hyperglycemia, lipidemia, uricemia, and calcemia.